I'm Mike Polson, and I'm happy to present our work on residential segregation, structural racism, and colorectal cancer outcomes on behalf of our co-authors. And unfortunately, this is very timely with the passing of Chadwick Boseman last night of stage 4 colon cancer. We have nothing to disclose. So as some background, there are well-documented racial disparities in colorectal cancer. Black patients have a 20% higher incidence when compared to white. Black patients are less likely to undergo surgical resection while having lower overall survival. There have been many proposed reasons around this, including tumor characteristics, socioeconomic status, comorbidities, and insurance coverage, but little has been looked into the built environment, particularly around segregation. And as a background to segregation itself, redlining and racist housing policies of the 1930s served to segregate Black Americans into urban centers of cities. Today, about 75% of those neighborhoods deemed hazardous are low to middle income, and 65% are still primarily minority neighborhoods. Studies have shown the impact of segregation on things like hypertension, cardiovascular mortality, and cancer mortality, particularly in breast cancer, prostate cancer, and lung cancer. So the purpose of our study was to understand the effects of structural racism in the form of residential segregation on Black-white colorectal cancer disparities. So we obtained patient-specific data from all patients with colon and rectal cancer from the SEER database between the years of 2005 and 2015. The SEER database provides county residents of patients included in the database, allowing one to compare this data. We obtained county-specific demographic, income, education, housing, and insurance information from the 2010 U.S. Decennial Census and the 2013 5-year estimates of the American Community Survey. The sample was then limited to Black and white patients living in the 100 most populous counties that do participate in SEER. Our exposure of interest was the index of dissimilarity, and this is a validated measure of segregation, which measures the geographic evenness or distribution of two groups. So here we looked at Black and white residents. And this is calculated from census blocks within each county to give a surrogate marker of segregation. And this ranges from 0 to 1, 0 being no segregation and 1 being complete segregation. And this represents the proportion of people within an area that would have to move to achieve complete integration. Our outcomes of interest were advanced stage of diagnosis, which we called stage 4, surgery for localized disease, which we called stage 1 and 2, and then cancer-specific 5-year survival. For advanced stage diagnosis and surgery for resectable disease, we estimated relative risk using a Poisson regression with robust error variance, controlling for age of diagnosis, sex, and region. For cancer-specific mortality, we looked at relative hazard, controlling for age of diagnosis, sex, region, and stage. For all of these, we did both a combined and stratified analysis. In the combined regression analysis, we incorporated race. And this allowed us to obtain predictions for Black and white patients at each level of the index of dissimilarity. And this allowed us to compare Black and white disparities across varying levels of segregation. The stratified analyses were done by race, and these assess the impact of segregation for Black and white patients alone. And these are baseline characteristics. So generally, Black patients presented at younger age, generally presented at more advanced stage, more often in stage 4, and were overall less likely to undergo surgical resection. So here you can see the stepwise model building for advanced stage of diagnosis, controlling for age of diagnosis, sex, and region. And I'll point you here in the final model, model 4, you can see that Black patients are 19% more likely than white to present at advanced stage. And the graph here on the left depicts the predicted proportion of people presenting at advanced stage by race based on the final model discussed in the previous slide. And as you can see, despite the levels of segregation here, the disparities persist between Black and white individuals in terms of presentation at advanced stage. And then here on the right, we report the stratified relative risk ratios of presenting at advanced stage with increasing segregation. And as you can see, Black patients are 41% more likely to present at advanced stage with increases in segregation. Similarly, white patients are 17% more likely to present at advanced stage with that same increase in segregation. And here is the stepwise model building for surgery for localized disease, again, controlling for the same covariates. And in the final model, model 4 here, you can see that Black patients are 2% less likely than white to undergo surgical resection. Again, here the graph depicts the predicted proportion of people undergoing surgical resection by race based on the final model from the previous slide. And as you can see, at lower levels of segregation, the disparities between Black and white patients disappear based on these confidence interval bars. And then on the right, again, we report the stratified relative risk of undergoing surgical resection. And as you can see, Black patients are 5% less likely to undergo surgical resection with increases in segregation, while white patients are 5% more likely to undergo surgery with that same increase in segregation. I do want to point out, though, that these are pretty small numbers and likely not clinically significant. And then finally here we have the stepwise proportional hazards models for cancer-specific 5-year survival. And as you can see in the final model, again, controlling for those same covariates along with stage, we see that Black patients have a 26% increased hazard of death when compared to white. The graph here depicts the predicted relative hazards of death by race based on that final model, controlling for the previously discussed covariates. And as you can see, despite the level of segregation, again, the disparities persist for Black and white individuals across all levels of segregation. And then again, on the right, here are the stratified relative risk ratios. And as you can see, Black patients have a 43% increased risk of death with increasing segregation, while white patients see no significant difference in hazards with that same increase. So taken together, both Black and white patients are more likely to present at advanced stage with increasing segregation, but this is more so with Black patients than white. Black patients are less likely to get surgery with increasing segregation, while white patients are actually more likely. And Black patients have worse cancer-specific survival with increasing segregation, while white patients see no difference. Despite relatively low differences between Black and white patients, these Black-white disparities in surgical resection for localized disease can potentially be eliminated at low levels of segregation. And unfortunately, despite improvements in advanced stage of diagnosis and cancer-specific survival among Black Americans at lower levels of segregation, Black-white disparities continue to persist across all levels of segregation. So our findings really challenge the notion that genetics alone contribute to the disparities we see in colorectal cancer. Black race, as we describe it in research and medicine, is a social construct that encompasses a vast array of genetic ancestries. However, the socially constructed group has been subject to a long history of structural racism with huge socioeconomic impacts and resulting health effects today. And it's this history of structural racism in the form of residential segregation and the historical loss of equity around redlining that affects the health of our patients. And these segregation effects have significant impacts on the built environment in which Black Americans live and can lead to significant intergenerational poverty. And it's likely these effects, these mediating effects, that are what drive the outcome differences we have seen in our study with colorectal cancer. Thank you so much for listening, and I will take any questions.
So good morning, everyone. I'm Tom Mottman. I'm from Indiana University. I'd like to thank everyone for the invitation to discuss this study today. So in this analysis, Dr. Powelson and his colleagues have evaluated a modern cohort of over 30,000 Black patients diagnosed with colorectal cancer using the SEER database. Using the racial index of dissimilarity, the study found that among Black patients with colorectal cancer, increasing residential segregation was associated with a more advanced stage of diagnosis and a decreased likelihood of undergoing surgery for localized disease. With increasing residential segregation, Black patients with colorectal cancer had significant increased hazard of cancer-specific mortality. I'd like to congratulate Dr. Powelson and his co-authors on this excellent study and presentation today. The findings of the study clearly highlight the disparities in healthcare among minority patients, and this is an extremely timely report given the events and conversations happening at a national level in our country today. This data adds to the growing body of literature outlining the disparities in colorectal cancer diagnosis and treatment among Black and minority patients. I've had the opportunity to review this manuscript ahead of this study, ahead of this conference, and it was an extremely well-written manuscript, and I encourage all in attendance to review it when it's ultimately published in the coming weeks. I have a few questions for Mike. Is it possible to place the index of dissimilarity into better context for the audience by giving us a few examples of well-known cities? Additionally, the group at Boston University has done excellent work evaluating social determinants of health, and this study is no exception to that. When studying racial disparities in healthcare, the fourth phase of the public health critical race praxis focuses on action by engaging communities and the healthcare system. How have the results of this study stoked discussion among you and your co-authors regarding community and healthcare system engagement, and what are your next steps? And finally, for myself and the other trainees attending this conference today, that are nearing graduation, what advice can you offer to us as individuals to address these disparities at the level of our local community and patient population as we begin our independent practice?
Great. Thank you for those great questions. So starting with the index of dissimilarity. So it ranges widely, generally as low as 0.2 all the way up to about 0.9. Detroit is one of the most segregated cities in the country. It falls almost at 0.9. And a lot of the Midwest is actually very segregated, and this kind of falls from Reconstruction after slavery and the Great Migration. As Black Americans fled from the South, they often ended up in the Midwest. And it kind of reflects that as well. Generally, the East and the South have middle of the road levels of segregation, and generally the West has some of the lowest. There are exceptions with cities, but generally, I believe it's like Pasadena or San Jose, California, it's about 0.4. And then as far as discussions, I think this really highlights that our patient outcomes are sometimes outside of our control. They are dictated by social norms and our history and policies. And I think it's important to truly study these and to use these for policy interventions, showing the impact on the care of our patients. And as I briefly mentioned, there are downstream effects of segregation, housing instability, especially with gentrification, that's now a huge issue, particularly in a lot of these neighborhoods, poverty. So our hospitals actually started investing in a lot of these things, given a lot of the findings that our group, as well as all other specialties in our hospital, have looked at. And then finally, I think as far as recommendations for trainees, I think we need to continue to serve as advocates for our patients on an individual level, and then even on a policy level as well, and continue to highlight these issues. Because unfortunately, there aren't many things we can do as physicians in the hospital to alleviate a lot of these factors. But I think one of the most concerning findings is that for advanced age of diagnosis and mortality, disparities persisted despite the level of segregation. And I think what is worrying about that is that there may be other factors involved, like provider bias, that may lead to some of these continued disparities. So these are things that were not directly studied in our study, but that should be addressed and thought about in future research. Hopefully I answered all those questions.
Thanks, Dr. Poulsen. Dr. Steen, you had a quick question?
Well, congratulations for a great paper. And I guess I'll ask a provocative question. While I agree with the conclusions, are you certain you adequately controlled for everything else? Socioeconomic, income, all those things, to really conclude that this is segregation rather than Black patients get poorer care. And I assume you've done that. I didn't read the manuscript, but I think as a reviewer for this paper, those would be the questions I have. Prove to me this was really segregation and not all the other factors which we know cause disparate care.
Thank you for that great question. And it's actually been brought up many times, but in our theoretical framework around this, we see segregation as kind of the overarching thing that has led to the socioeconomic effects. So we see a lot of the socioeconomic factors being mediators in this pathway. So we did not control for them in these analyses, and the analysis that we did was not amenable to mediating factors, but we have future research coming out to look at the mediating effects of these socioeconomic variables on the impact of segregation.